Yes, sir.
Good morning, everyone. This is Dr. Snigdha Reddy. Today, I'm going to tell you people about capnography. Capnography in day-to-day life as per anesthesia, as per anesthetist, it plays a vital role in present era. Let's get familiar with the terms first. Capnometry means measurement. Capnography means it's a method. It's not only for method of carbon dioxide measurement, but also its graphic display as a function of time or volume. Like that, there are two types: time and volume capnography. Capnometer means it's a metric value, numerical value of inhaled or exhaled carbon dioxide. A capnogram, however, it's a device that records and displays carbon dioxide concentration, usually as a function of time. Whereas capnogram is a graphic display that the capnograph generates. This capnograph, basically, it's a device which generates the capnogram. Capnography refers to study and measurements of carbon dioxide in exhaled gas. It was first introduced by Karl Luft, a German bioengineer, in 1943, where he used infrared carbon dioxide measuring device. He called them, it has URAS, ultra rod absorption chamber. It was very heavy, big, and impractical to use. So as it was impractical to use, like many people, they started using it different ways, and finally they have got it to a compact, like easy to use device. According to the study of ASA, 93% of all avoidable anesthesia related incidents would have been prevented if the capnography was used with pulse oximetry. In 1998, ASA Committee on Standards of Care deemed it mandatory that patients receiving general anesthesia to be continuously monitored by using this ETCO2. Nowadays, capnography is used successfully in almost all areas of healthcare, starting from operation theater to ICU. In pre-hospital setting, capnography has various uses and indications. From pre-hospital setting to operation theater to ICU. In pre-hospital settings, these paramedics frequently use carbon dioxide detection devices to assist ensuring that endotracheal tube is properly placed. Whereas in emergency medicine, it is frequently used for proper ET tube placement and to ensure if mechanical ventilation is adequate or not. And heart rhythm on the monitor is not pulmonary embolism. Critical care medicine in ICU, capnography can be used to trend ventilation during mechanical ventilation. Watch for any changes in dead space ventilation and any pulmonary related disease processes. While doing CPR, it shows the efficacy of CPR, or if patients are prognostic wise, if patients are able to be revived by CPR or not. Procedural sedation. During conscious sedation, capnography is a much faster indication changes in respiratory status than pulse oximetry. It can take several minutes for saturation to change, but EtCO2 almost changes immediately. So based on this, like it's better than pulse oximetry for this procedural sedation. Anesthesia. Capnography in the OR has been a standard of care since 1998. It is used to maintain adequate ventilation, to monitor changes in dead space ventilation, and assure the presence of adequate cardiac output during surgery. Capital A means CO2 means partial pressure of carbon dioxide in the alveoli. If it is small a, it's partial pressure of carbon dioxide in arterial blood. If it is PET CO2 means partial pressure of carbon dioxide at the end of expiration. And A minus ET is the difference between arterial and end-tidal carbon dioxide. PvCO2 is partial pressure of carbon dioxide in venous blood. Usually, this respiratory cycle, it consists of two components. Basically, it's inspiration and expiration. So first, to understand about capnography, we need to know about oxygenation and ventilation. which are both different entities, but respiratory cycle totally rely on that. Oxygen basically relies on inspiratory phase, and ventilation relies on expiratory phase. And amount of carbon dioxide produced during metabolic cycle of cells and exhaled from the body. Oxygenation and ventilation, they both are needed in proper proportion to sustain an adequate and sustained quality of life. So let's come to physiology of behind this capnography. Actually, production of carbon dioxide, it is a result of cellular metabolism. So this capnography is basically like it completely revolves around carbon dioxide production, transport, and exhalation. So coming to production of carbon dioxide, during aerobic cellular metabolism, carbon dioxide is produced when we burn glucose and oxygen to produce energy in the form of ATP. Just like combustion engine that burns fuel for power, there is also exhaust or waste produced. These exhaust or waste products of aerobic cellular metabolism are mostly water and carbon dioxide. The excess water is eventually transported to kidney, where it is converted into urine and leaves the body via urination. The carbon dioxide which is left behind is transported to lungs, where it diffuses across the alveolar capillary membrane and then leaves the body via expiration phase. So there are many methods to used for detecting and measuring carbon dioxide in exhaled gas. Mainly chemical calorimetric analysis, it's mostly used in pre-hospital setting. Infrared spectrography, it's mostly used in hospital setting. And molecular correlation spectrography, it's microstream technology. Other methods use are Raman spectrography, mass spectrography, and photoacoustic spectrography. Now, the principle behind capnography is infrared spectrography. The technology used is most carbon dioxide monitors. It works on the principle that carbon dioxide selectively absorbs only a specific wavelength of infrared rays, which is 4.3 millimicrons. The amount of this light is directly proportional to concentration of carbon dioxide molecules. So this picture shows that the more the carbon dioxide molecules, the more light is absorbed and less light goes to the detector. So this is the infrared source which emits infrared radiations of specific wavelength. But in that specific wavelength, carbon dioxide absorbs only 4.3 millimicron wavelength of infrared radiations. It absorbs few IR radiation, and it finally the leftover radiation come to the detector. A predetermined amount of infrared radiation is sent from the emitting side of the sensor through a gas sample and collected on the receiving side of the sensor, that is detector. The infrared light is received is compared to the infrared light transmitted. The difference is then converted by calculation into partial pressure that we can see on the monitor. Now, the advantages of this carbon dioxide monitors is like it provides a measured concentration of carbon dioxide present in the sample. It provides a breath-by-breath waveform and measurement that can be used to help determine the patient's airway and gas exchange condition. It can detect, measure, and monitor very small amounts of carbon dioxide even in the exhale gas, which is less than 1% also. So can accurately measure carbon dioxide during CPR also. What are the disadvantages is it takes longer to show after endotracheal intubation. The graph takes time to reflect on the monitor. Sensors can be bulky or heavy at the end of the ET tube, which might cause accidental disconnection of ET tube. Sample tubing or electrical lining attached to ET tube can increase risk of unplanned extubation, so which might result in sudden airway emergency. So we should be cautious while using especially mainstream analyzers, mainstream capnography, which I'll tell in further slides. Most units require some maintenance and supplies like batteries, adapters, and all. It might be expensive also. So the picture shows the IR source is emitting IR radiations. The carbon dioxide molecules are absorbing the radiations, and the remaining radiations are going to the detector. So the more carbon dioxide present in the sample, the less radiation goes to the detector. This is another picture showing that, like, if carbon dioxide molecules are less, the IR radiation going to the detector will be more, because less radiation is absorbed by the carbon dioxide. If the carbon dioxide concentration is more in the sample, more radiation is absorbed by the carbon dioxide in the sample, and less radiation goes to the detector. So there are basically two types of capnography: mainstream and side stream. In mainstream, as the picture shows, the sensor is present directly near the ET tube, between ET tube and the circuit, and the wire connects from sensor to the monitor. Whereas in side stream, a sampling tube will be there, which takes carbon dioxide in the gas sample to the monitor. The sensor is present in the monitor itself. So mainstream, what are the advantages of this mainstream is, so there is no sampling tube, there is no obstruction, and there is no variation due to barometric pressure changes, and there is no humidity variation due to humidity changes also, because there is no sampling tube and there is no water vapor changes in the sampling tube. Direct measurement means waveform and readout are in real time. There is no sampling delay, because the it is directly present between the ET tube and monitor itself. Suitable for pediatrics and neonates. But there are few disadvantages which we should consider. That is, because of its weight at the end of the endotracheal tube, it should always need to be supported, because it might lead to accidental disconnection. In older models, there were minor facial burns are also reported, because it is closer to the patient. The sensor windows can become obstructed with secretions and water rainout. Sensor and airway adapter can be positional. As it is positional, it's difficult to use in unusual positions like prone or side lateral positions. Now, side stream, coming to advantages, because of the sampling capillary tube and airway adapter, it is easy to connect. Single patient use sampling, no issues with sterilization. Can be used with patient in almost any position. As the sampling tube is long enough, 6 feet, we can use it in any position, like lateral, prone, or any position. Can be used on awake patients, or also while using via nasal cannula. Carbon dioxide reading is unaffected by oxygen flow through the nasal cannula. So simultaneously, we can use oxygen device, and we can also we can also monitor carbon dioxide even. But coming to disadvantages, as we are using this sampling tube, it might be easily obstructed with water or secretions. Water vapor pressure changes within the sampling tube. It might affect carbon dioxide measurement. Waveforms of children are often not clear or deformed. That is the reason in children we use mainstream analyzer. Delay in waveform and readout time due to the time, as it is sampling tube is 6 feet long. It takes time to detect the graph on the monitor, as the gas has to travel to the sensor within the unit. Now, coming to capnogram, here it shows the capnogram. It has basically 4 phases, and phase one, it's usually dead space. What is dead space means? Ventilation occurs, but there is no gas exchange. Uh, uh, Phase 1 is the onset of expiration, which contains only dead space gas of the airway. This phase 2 is the upward slope that contains a mixture of alveolar gas and dead space gas. That is the reason in phase 1, because the dead space gas doesn't contain carbon dioxide, and as there is no gas exchange, it's like zero. Coming to phase 2, it has upward slope, because there is a mixture of dead space gas and alveolar gas. Alveolar gas will have carbon dioxide, right? So there is upward slope. Phase 3, it's also called alveolar plateau. It contains only alveolar gas. Phase 0, which is onset of inspiration, because during inspiration there is no carbon dioxide which we get in. That is the reason it drops to 0. So this shows during phases of inspiration and expiration how the capnograph generates. See, during this red line, it shows like inspiration, start of inspiration and white line, it shows from transition from inspiration to expiration. So during inspiration, as there is no carbon dioxide, it is baseline, it's 0. And during inspiration, actually this is baseline is because of dead space doesn't contain any gas exchange. That is the reason it is 0. During upstroke, it's a mixture of alveolar gas and dead space gas. That is the reason there is upstroke. And the plateau depicts only alveolar gas mixture. And the deceleration curve, the downstroke, it depicts inspiration. The capnogram has two angles. There is alpha angle between phase 2 and phase 3 and beta angle between phase 3 and phase 4. So a decreased alpha angle, it indicates partial airway obstruction or ventilation perfusion mismatch. Whereas the beta angle, which is decreased, it can indicate carbon dioxide rebreathing. A decreased alpha angle indicates a prolonged expiratory phase, which is often seen in bronchospasm or partial airway obstruction. The beta angle, which is decreased, is indicative of partial rebreathing or foreign body obstruction. Excuse me. The presence of phase 4 on the capnogram indicates unusual emptying between the left and right lung. This can be caused by unilateral bronchospasm or partial airway obstruction within left or right bronchial tree. So now, what are the indications for use of capnographies? While using for endotracheal, it can be used during endotracheal intubation to ensure if proper ET tube is properly placed or not, because there are chances of and esophageal intubation in freshers especially. Procedural sedation, continuous monitoring of respiratory pattern. We choose depth of respiration, how much patient is sedated and all. Mechanical ventilation, it also changes it's also used for monitoring effects of ventilator settings changes. General anesthesia, in general anesthesia to monitor pulmonary and cardiac output changes. While using CPR, it monitors effectiveness of chest compressions and predicting the outcome of CPR. While using chest compressions, we should if it is less than 8 mm, the prognosis is very low of chance to of the patient being survived. If it is more than 18 mm, yeah, there are pretty good chances of survival. Capnography during endotracheal intubation. As the carbon dioxide is a waste product of cellular metabolism, it leaves the body during expiratory phase of the respiration. If cardiac output is stable and the airway is patent, then carbon dioxide is present in the exhale gas. It is usually this carbon dioxide is not present in the stomach, right? So if the endotracheal tube is in the stomach, in the esophagus, the capnograph doesn't show any graph. Capnography should be initiated immediately after endotracheal intubation. But we can't rule out esophageal intubation using this capnography if the patient has taken any carbonated beverages just prior to intubation, because the carbon dioxide measurement will be positive for first 4 to 5 breaths. Capnography, after an inadvertent esophageal intubation, a false positive capnographic reading can be caused, as I told, because of recent consumption of carbonated beverages or exhaled gas entering the stomach during aggressive bag mask ventilation. When the bag mask ventilation is aggressive, carbon dioxide may enter the stomach as the exhaled gas enters the stomach. A significant tracheoesophageal fistula can also cause the exhaled gas to enter the gastrointestinal tract. Use of capnography during procedural sedation, because capnography is a vital sign of ventilation. The capnographic waveform directly correlates with ventilation. Changes in respiratory status can be detected instantly when capnography is properly used. It can go, changes in the respiratory status can go undetected for up to 5 minutes when being monitored with pulse oximetry alone. But when capnography is used, it's immediate changes can be detected. During procedural sedation, capnography should be used in conjunction with pulse oximetry. During mechanical ventilation, capnography plays a very important role, especially in ICU settings. When a critically ill patient is on mechanical ventilation, oxygenation and ventilation both are to be monitored. Oxygenation, basically it's monitored using ABG, and non-invasively it's monitored by pulse oximetry, whereas ventilation is monitored using this capnography and ABG also. When used properly, capnography can help you to manage intubated patients with fewer ABG samples. So after anesthesia induction, capnography is first used to verify ET tube placement after endotracheal intubation. During surgery, it is used to monitor airway status, ventilatory status, and pulmonary perfusion status. Airway status, based on the change in shape, which it can detect many respiratory problems like bronchospasm or dislodgement of ET tube, or accidental disconnection of ET tube from the circuit. Ventilatory status during surgery, a sudden change in end-tidal carbon dioxide can alert anesthesiologist to see for changes in ventilatory status. Like there may be sudden pulmonary thromboembolism, showing different capnograph waveform on the monitor. Perfusion status. A sudden decrease in end-tidal carbon dioxide can also mean an acute decrease in pulmonary perfusion. So basically, capnometry, it shows perfusion status, ventilatory status, airway status during general anesthesia, during its use in general anesthesia. Pulmonary perfusion is directly proportional to carbon dioxide, exhaled carbon dioxide. So capnography during CPR, it has benefit, it has lots of benefit, and several studies have been published supporting its use. With an intubated patient, if manual ventilation is consistent, then EtCO2 can help to determine if chest compressions are effectively circulating blood to the vital organs. So mostly, most people can only perform effective chest compression for a maximum of 3 minutes before beginning to fatigue. So studies show that if EtCO2 is less than 8 mmHg, then the survivability is less than 1%, as I earlier told. If EtCO2 is initial EtCO2 is more than 18, then there's more chances of survival. It must be understood that outcome is also dependent on the cause of the cardiopulmonary arrest. So then there is difference between carbon dioxide, partial pressure of carbon dioxide in exhaled gas and partial pressure of carbon dioxide in the arterial sample. And the difference is around 3 to 5 mmHg. It is called carbon dioxide difference or carbon dioxide gradient. So the difference is directly proportional to the amount of dead space ventilation. There is the clinical significance in both measurements, that is EtCO2 and difference gradient. So EtCO2 and cardiac output, it's directly proportional. EtCO2 is directly proportional to cardiac output and pulmonary perfusion. If ventilation is consistent, then any sudden change in cardiac output or pulmonary perfusion will result in the sudden change in EtCO2. So the picture depicts if this is normal, like if there is sudden change in cardiac output or pulmonary perfusion, there will be sudden change in EtCO2. So as there is sudden change, a sudden increase in cardiac output or pulmonary perfusion, there is sudden rise in EtCO2. As there is sudden decrease in cardiac output or pulmonary perfusion, there is sudden decrease in EtCO2. The difference between EtCO2 and PaO2 is often referred to as gradient, carbon dioxide gradient. There is a clinical significance in this difference, which is representative of and directly proportional to alveolar dead space. So the difference in the gradient is usually directly represents alveolar dead space. So the red line depicts PaCO2 and the alveolar plateau depicts EtCO2. So as the dead space, as the alveolar dead space increases, the difference also increases. There are several conditions or disease states that will cause increase in this difference, which is pulmonary embolism, emphysema, low cardiac output states, hypovolemia, and it also increases with age. So what are the causes of increased EtCO2? Based on metabolism, if there is increased metabolism, like high metabolic states include pain, hypothermia, shivering, and respiratory causes wise, respiratory insufficiency, respiratory depression, and COPD, analgesia, sedation, and perfusion wise, increased cardiac output, and medications wise, bicarbonate. These are all reasons for elevated EtCO2. Hypoventilation mainly, and causes of decreased EtCO2 because of low metabolism conditions like hypothermia, metabolic acidosis, and respiratory conditions wise, it's because of hyperventilation. As we hyperventilate, the carbon dioxide, like it, during hyperventilation, the carbon dioxide is drained out easily. Bronchospasm, mucus plugging, and circulatory and perfusion wise, hypotension, sudden hypovolemia, cardiac arrest, and pulmonary emboli. These are all causes of decreased EtCO2. And the changes in gradient, increased difference, increased difference in gradient causes are emphysema, pulmonary embolism, low cardiac output state, and hypovolemia. Slight increases with age also. Decreased gradient is due to pregnancy, young children, and high tidal volume and low respiratory rate settings. Young children and infants normally have less dead space, so the decrease is less. Capnography is very fast indicator of many problems and can arise during ventilation, which can arise during artificial ventilation. In most cases, this capnography responds much faster than pulse oximetry, which can sometimes take 3 to 4 minutes to show a change in respiratory status. The measured EtCO2 alone, while important, is of limited value. In many cases, it is a waveform. More than the number, the waveform depicts a large number of diseases and pathologic states and physiological status of the airway. So the number alone is not enough. The graph is must, and the continuous graph recording is must to tell the problems of airway and perfusion status. So let's view a few capnographs. Here there is a sudden loss of EtCO2, which are seen in conditions like when airway is disconnected or ET tube is kinked. In these conditions, as the ET tube is kinked and airway is disconnected, there is no the exhaled gas is not coming out to the sensor till monitor. That is the reason the carbon dioxide EtCO2 suddenly dropped from normal plateau. Airway obstruction and ventilator malfunction also causes sudden loss in EtCO2. Now, consistently low EtCO2 is because of high alveolar hyperventilation, hypothermia, increased dead space ventilation, and during sedation and anesthesia also. Suddenly high EtCO2, it is seen in alveolar hypoventilation, malignant hypothermia, pain, shivering, respiratory depression, rising alveolar plateau. This typical shark fin appearance will be seen in bronchospasm, mucus plugging, partial airway obstruction, partially kinked DT tube, and prolonged expiratory phase. This is a typical shark fin appearance of capnograph. Rapidly decreasing EtCO2, the EtCO2 will be dropped off gradually, rapidly from higher to low value. Onset of cardiopulmonary arrest, developing pulmonary embolism, or increasing dead space ventilation, or sudden hypotension or sudden bed loss. Rapidly increasing EtCO2 is because of high body temperatures during fever, increased metabolism, and progressing alveolar hypoventilation or partial airway obstruction. Mainly in partial airway obstruction, the typical shark fin appearance is seen. Rapidly decreasing EtCO2, which we have already told. So these are other capnographs. As I told, in bronchospasm, asthma, like in COPD conditions, or any foreign body in the airway, or partially kinked or occluded airway, this typical shark fin appearance is seen, where the plateau is lost, the alveolar plateau is lost, and there is a high slope, upslope of the plateau. and increasing EtCO2, which we have already seen, hyperventilation, decreasing EtCO2, and this rebreathing causes the graph to go away from the baseline. And this curar cleft, which we missed earlier, this is seen, the typical notch is seen in the alveolar plateau. It shows that the patient is trying to inspire on his own, trying to take spontaneous efforts. So during the spontaneous efforts, the exhale gas is little, right? So there is a notch seen in the alveolar plateau. This is clefts, curar clefts, which is seen in a spontaneously breathing patient who is mechanically ventilated. In cardiac arrest, the capnograph shows like it drops continuously to 0. And during return of spontaneous ventilation, if it is more than 18, there is success that it is successful. If it is less than 8, there are more chances that the patient might not survive. Now, coming to technological innovations behind this capnography, real-time data integration. It aims to enhance patient monitoring by providing instant feedback on capnography readings, allowing for rapid adjustments and improved patient outcomes. Wearable capnography solutions. It offers continuous monitoring of respiratory status, so it encourages mobility of patients, ensuring critical data is captured and analyzed promptly. Use of capnography in emergency medicine in pre-hospital care for effective monitoring in pre-hospital settings to enable rapid assessment and stabilization of patient, and ensuring continuity of care during transport to medical facilities. While transporting to medical facilities, even it is used. Rapid diagnosis, because of rapid diagnostic tools and monitoring facilitate swift identification of critical condition, allowing for early intervention in emergency medicine. So if the condition is detected earlier using this capnography, the more earlier we detect, the more earlier we treat the condition. We take the step to survive the patient. Now, in critical care, it's used for ventilation monitoring and cardiac arrest and resuscitation and prognosis and outcome prediction also. In anesthesia, it's used for monitoring sedation levels, as we earlier discussed, identification of respiratory complications, like if there is any pulmonary thromboembolism or any mucus plugging in the ET tube, or any patient is suddenly developing fever or high temperature, the graph shows different. And if patient has, if there is any ventilator malfunction also, if there is any expiratory valve defects, if there are any inspiratory valve defects, it also clearly shown up in capnography. So outside the operating rooms, capnography has a vital role, various roles like in angiography, cath labs, while using, like it is also used in transportation of patients from one hospital setting to different hospital settings, and post-operatively in an ICU, PACU, and emergency department, and in endoscopy also it is used. Thank you so much.
Yeah. Okay, doctor. So, just